Hi, everyone. I'm Jason. I am a data engineer in the Columbia University Department of Biomedical Informatics. I completed my master's in the department last year, and this is a paper that resulted from my research. So the paper is titled KG Lyme, Predicting Individualized Risk of Adverse Drug Events for Multiple Sclerosis Disease-Modifying Therapy. And here's the paper, which was published in JAMIA, the Journal of the American Medical Informatics Association, in July. So feel free to check it out. So the disease of concern is multiple sclerosis, which is an inflammatory and demyelinating autoimmune disease of the central nervous system. And symptoms vary amongst patients, but typically they're neurological in nature. So that includes tremor, neuropathy, muscle weakness, various cognitive issues. And it's quite prevalent, especially among young populations. And it's growing annually in the US and worldwide. So typically, the treatment of multiple sclerosis is performed through the application of immunosuppressive drugs, which slow the relapse rate. And these drugs can generally be divided into categories of moderate efficacy and high efficacy, with high efficacy drugs tending to be monoclonal antibodies. And there's a known trade-off between the level of efficacy of the drug and the frequency and severity of adverse drug events that result. And that's in the average drug events, or ADs, are specifically what we're interested in looking at in this study. So we had the aim of building AD risk score prediction models for several FDA-approved multiple sclerosis drugs using time series of EHR OMOP concepts. So those time series are represented starting with an index DMT drug exposure, which is preceded by an observational window of a sequence of EHR condition, drug, and abnormal measurement concepts. So just concept IDs in sequence. And after that observation window, we create a 12-month prediction window looking for the occurrence of the ADE in the form of a condition concept. And we decided to represent our OMOP concepts in the form in a computable form of graph embeddings, which I will explain. So we wanted to take advantage of the format of OMOP as a knowledge graph to extract some utility from it. So what we wanted to do is take OMOP as a backbone, the OMOP vocabulary, and integrate other ontologies into it to create a combined knowledge graph with each node being a standard OMOP concept. So with OMOP at the center, we integrated a ontology from our own lab called the onsides to get known adverse drug effect and drug pairs. We used another resource called Drug Central to get known drug indication pairs, and we used another resource from a group called the Monarch Initiative to get abnormal measurement and related condition pairs. So we combined all those into the vocabulary using non-standard vocabularies and then converted them to standard concept IDs. And what that gave us was a what we call a metagraph of 3 node types, so condition concepts, measurement concepts, and drug concepts, connected by 6 different edge types. So those edge types include conditions associated with high measurements, low measurements, conditions, drugs that have indications for conditions, as well as hierarchies that come directly from OMOP. So subsumptions, conditions consumed by higher conditions, drugs consumed by higher drugs. And an example of this on the right is an insulin subgraph. Insulin has an indication of diabetes, which is associated with high glucose in blood, glucose in serum plasma, and so on and so forth, which gave us about 13,000 nodes and 190,000 edges. So we used those this resulting graph to create what are called graph embeddings, which are vectors that describe the nature of a node in the graph. And the way these graph embeddings are trained, where they were trained using a network called a graph convolution network, which learned the representations through a link prediction task. So we would randomly remove links within the graph and then try and predict them. And the resulting nature of the embeddings was that similar nodes would have similar representations. And by similar, here's one way to view this. Here are UMAP projections, low dimensional visualizations of high dimensional data, so of the embeddings themselves, with each stop being an embedding around a certain neighborhood. And these colors represent concepts that are related to a central concept in blue, pre and post training. So pre-training, these concepts are scattered throughout the cloud, but following training, they begin to localize very well. So concepts that are similar begin to appear similarly in vector space. So what do we use this for? So we plug these embeddings into an LSTM model, which is a recurrent model, which takes the sequence of OMOC concepts and time components, looks at the embeddings, and then pass them through a series of layers in order to predict the risk or probability of an ADE occurring. And we trained on 12,000 different drug exposure sequences from our CUIMC OMOP instance, and we trained 56 different models for 56 different adverse effects in total. Additionally, we want to leverage the knowledge graph to add some explanation capability to the model. And we did this by modifying the popular local interpretable model agnostic explanations, or LIME framework, which essentially performs a counterfactual explanation by perturbing the input. And the way we did this is we took an original sequence with the trained model. We looked up the concepts in the knowledge graph. We created distances between the concepts using our embeddings, and created sampling probabilities such that we could randomly replace concepts in the original sequence with concepts in its neighborhood to see how the prediction changed. And using those changes as features for a decision tree, we're able to figure out the concepts that had the most impact on the changes in the predictions. And here are some results. So here are the results of the model predictions themselves. Generally, they perform pretty well. We found the mean AUC across all 50 plus models to be 0.77 plus or minus 0.15. Particularly, we found that adverse effects that dealt with low blood cell counts were among the highest performing, which makes sense because if you remember, I mentioned these drugs are immunosuppressive, so blood cell counts are affected. Not all performed well, particularly adverse effects with low sample size performed poorly because there wasn't a strong enough signal. That seemed to make sense. And we also generated some explanations from our explanation module. And these are some individual patients and explanations that result from them. And generally, we found that past medical history of the adverse effect is a strong predictor of the future occurrence of the effect. And we also found that those MSDMT drug signals were appearing strong as well when relevant, along with relevant labs such as leukocytes in blood and urine. And here's a similar view of those individual patient explanations aggregated across entire cohorts. It's a bit of a busy slide, but the takeaways are that recent concepts have the strongest influence the 0 to 7 day before the index event time bucket. And the multiple sclerosis DMT is often important as features. Some takeaways are the ontology-derived graph embeddings can be used for the adverse drug event prediction. We didn't fine-tune the embeddings at all when we plugged them into our model. We just used them straight, and they work pretty well. Our KG-LIME explanation module can provide some feature importances. It's not causal. I'm not a causal inferences person, but I would like to meet up with some or collaborate with some causal inference experts to see if it can be made causal in some form. But there are several limitations. We chose an arbitrary time window of 12 months for the prediction window. But You can imagine adverse events can happen within a day of administration, or it could happen years after administration. So we will play around with other windows. And extremely rare events were difficult to predict, as expected. And an overall limitation with the bias of EHR data is that it'll have gaps. Patients can be receiving care in multiple institutions, so we may not know everything about their healthcare trajectory. So we are looking at some next steps of exploring all these limitations and seeing how we can mitigate them. Yeah, thanks for listening.